We also looked at the subtype of adenocarcinoma and the EGFR mutation status associated with the administration of adjuvant chemotherapy for matching. The primary endpoint of this study was a 5-year recurrence-free survival. Coming to the results, there were about 475 patients in total. Of this, about 183 were EGFR positive, 292 were either EGFR negative or their EGFR status was unknown. In this group, 36% patients received chemotherapy, 64 did not. In the EGFR positive subgroup, about 42.6% received chemotherapy, 57.4% did not. The propensity analysis for 5-year RFS was done in 80 pairs of patients with EGFR negative or unknown status and 64 pairs for EGFR positive patients. And if you look at the recurrence-free survival in EGFR negative patients or unknown status patients, chemotherapy definitely had an advantage of 5-year RFS of 86.8% compared to 70.9% where chemotherapy was not given, with a p-value of 0.009. However, in patients who were EGFR positive, the chemotherapy did not make any difference. In fact, the recurrence-free survival was 75.9% versus 79.7%. So the authors have concluded that in high-risk stage 1 lung adenocarcinoma, the results of adjuvant therapy definitely are different as compared, determined by the or stratified by the EGFR mutation status. And EGFR mutation status could be or should be tested in patients who have high-risk stage 1 lung adenocarcinoma to help decide what is the role of adjuvant chemotherapy. To my take on this is, obviously this is a retrospective study. Is this a practice-changing study? I think we need more prospective trials to reach that conclusion, but this is really a thought-provoking study. Although this is a very small number of patients, we are also looking now at a lot of adjuvant TKIs in patients who are EGFR positive. So is there any role for TKIs in this subset of patients? So these are the questions that remain, I think, in my mind at the end of this study, but certainly a very thought-provoking study. Thank you.